Hello, and welcome to the GRACE podcast series. My name is Denise Brock, and I am the Operations Director for the Global Resource for Advancing Cancer Education, or GRACE. In this podcast series, we interview patients, advocates, and healthcare professionals to provide the most updated information for our community and to highlight important issues facing those dealing with a cancer diagnosis. We hope you find this information valuable. For questions or comments, please visit us at cancergrace.org.
Welcome to 2024 updates in head and neck cancer. This is our update on HPV negative curable cancer. Just as a brief reminder, we've learned in recent years that the human papillomavirus, the same virus that we know and hate from cervical cancer and anogenital cancer, can also cause a lot of cancer of the oropharynx, meaning the tonsil and the base of the tongue, and that these have a much better prognosis than the cancers not driven by this virus. Our focus in this segment is cancers not driven by this virus. And the problem here is that they're hard to cure. In general, we cure less than half of locally advanced HPV negative cancer, despite very intense treatments. And so, of course, as a field, we're desperate to try to do better. Let's get the bad news out of the way first. Dr. Patel, can I ask you, what have we failed on recently?
Well, there's been a lot of excitement in the area of immune checkpoint therapies broadly across a lot of different cancer types. And this has been something that's changed our practice in patients with recurrent and metastatic head and neck cancers. So naturally, it was important for us to look at this at earlier stages of disease to see if we could use immune therapy as a way to improve cure rates, as Dr. Weiss mentioned, in those patients that don't have those high cure rates. And unfortunately, we've seen that this strategy of adding immune checkpoint inhibitors in combination with chemotherapy and radiation therapy, as well as doing it after completion of chemotherapy and radiation therapy for locally advanced head and neck cancers, has not improved survival rates. So these are therapies such as pembrolizumab or atezolizumab, which is an immune checkpoint inhibitor. And unfortunately, those have not improved our cure rates for this disease. And so we're going back to the drawing board to try to really understand, are there ways that radiation interacts with the immune system that's different in our head and neck cancers that's led to these negative trials, or maybe there were subsets of patients that do benefit that we can focus on in future studies. But as a broad approach, that unfortunately has not improved outcomes.
Sorry for giving you the sad one, but Dr. Sheth, my gift to you, what's our happy, hopeful news here?
Yeah, I think our hopeful news, and something that was came out a couple years ago, but very relevant for this year too, is an agent called xevinapant. And so this is an oral agent. It's called an IAP, or an inhibitor of apoptosis, which basically can lead to cell death. And so what these agents have shown is that if you can give this therapy, xevinapant, in combination with radiation therapy, it might actually increase or restore the cancer cell sensitivity to cell death. And so what it's shown is that it's really been able to improve overall efficacy, or how well it works when it's combined with chemo and radiation therapy. And so what the phase 2 study showed was in a 5-year overall survival, so from time of starting treatment to when a patient died, there was a doubling in the overall survival, which was very, very impressive for this disease space. And so based on those results, it has now been studied in a phase 3 fashion to see if we can confirm those results. And it's really being studied kind of in 2 flavors. One in what we call the definitive setting, so with chemoradiation therapy and a non-surgical approach, and the other is in a post-operative or adjuvant setting, so a patient gets surgery and then it's followed up by this agent with xevinapant with radiation therapy, who are not typically eligible to get cisplatin, and these are patients that have what we call high-risk disease. And so I think what we may see from either or both of these trials is that if it is confirmed in a phase 3 setting, it may change our standard of care and how we treat all patients moving forward. So exciting stuff, and maybe some data that's going to come out later this year.
Yeah, I'm really excited. Not all positive phase 2s turn into positive phase 3s. We've been stung by this before in head and neck cancer land. But still, if the phase 3 is even half as good as the randomized phase 2, this could make a massive human difference. And I think it's something that all of us are looking forward to with anticipation for the phase 3 to confirm that it's true. Well, thank you for joining us for this segment on HPV negative curable disease.
Thank you again for joining us. This podcast was made possible by the generosity of our sponsors and you, our community. Please like and follow us on YouTube, Facebook, Twitter, LinkedIn, and Instagram. Send us feedback, share your story, donate, and visit us for more information at cancergrace.org. Thank you for listening.